you, and we'll turn now to our second panel. I will introduce them as they begin to come on the screen. This second panel is going to focus on interventions within the health sector designed to address housing and housing-related social needs. We'll hear from MaryCatherine Arbour at the Brigham and Women's Hospital, Katie Huber at Duke University, and Alec Chapman at the University of Utah. They have three, again, quite different papers that look at different dimensions of the relationship between the health sector and housing. MaryCatherine, I'll turn first to you.
Thank you so much. I'm very happy to be here to present the findings from an evaluation of a housing intervention executed in Brigham Primary Care that reduced outpatient visits, and patients reported improvements in mental and physical health. This is the work of a team. The research team is on the screen, and I'll share with you the implementation team at the end of this presentation. This is a work of many people. Next slide, please. So to start from a common definition, housing instability, which is the lack of access to safe and affordable housing, is associated with poor mental and physical health, less effective healthcare engagement, and higher costs. And I think the last three presenters did a great job outlining that these inequities are rooted in unfair historical policies. So on the left, you see a map of redlining in Boston, and on the right, you see the distribution of heart disease hospitalizations by neighborhood, and the darker areas have higher hospitalization rates, and they overlay the areas of historical redlining. Now, what we know, and we'll see on the next slide, is that the COVID pandemic exacerbated those inequities. So in August 2020, 1 in 3 Massachusetts renters reported that they were unable to pay their rent, but that was not shared equally among all renters. You can see that 50% of Black renters, 39% of Hispanic renters were unable to pay their rent, as compared to only 15% of white renters. And on the right, you see a graph that shows the larger the orange dot is, that is the higher rate of eviction filings by neighborhood. And as you move to the right, there's a greater proportion of people of color in the neighborhood. And as you move from bottom to top, there's a greater COVID incidence in the neighborhood. So what this shows is that neighborhoods with people of color tended to have higher COVID incidence and much higher, double the rates of eviction filings. In that context, the Brigham Center of Excellence for Primary Care developed an upstream housing program that was focused not only on supporting patients who were unhoused, but also those who were at risk of homelessness. And we focused on preventing eviction. Next slide. The Brigham and Women's Hospital is a large academic facility in Boston, in the greater Boston area, and the primary care services include 15 primary care clinics serving about 190,000 patients. Next slide. We began screening in primary care for social determinants of health in 2018, which is when Massachusetts Medicaid introduced SDOH screening as a requirement. And the graph on the left shows that every year we increased both the number and the proportion of our patients who we screened for 8 domains of social need. On the right, you see the prevalence of those needs in our primary care population. And 50% of Brigham primary care patients are screening positive for 1 or more social determinant of health or health-related social need. And more than 30% screen positive for housing needs. Next slide. As our screening rates increased, the number of referrals for housing needs to our social care team increased from 20 per month in 2020 to 100 per month in that same year. And then by the end of 2022, it was 250 housing referrals per month. And by the end of 2023, it was 350 referrals for housing needs per month. Now we know this because we have a single centralized order where any provider or staff member can send a patient with an identified social need to our social care team. And that team has several roles and many people who respond to those needs for the 15 clinics in partnership with the clinical teams. Next slide. For this housing intervention, we used a team-based triage approach to enable upstream housing intervention. The first role on our team is a community resource specialist. They are the first responders, and they reach out and support 60 to 80 patients per month with any of those social needs, any one of those 8 domains. And they provide short-term telephonic support with resource information. But when they find patients who have a higher level of need for care management or navigation, they can escalate the case to a community health worker or for housing needs that meet certain criteria, they refer them to a housing advocate. The housing advocate is a specialized community health worker, and we tried to focus their work on patients who were unhoused, at risk of eviction, or living in unsafe or unhealthy housing conditions. And the entire team is supported by a partnership with medical legal partner Boston, MLPB, that conducts biweekly multidisciplinary case review. Next slide. To move upstream, that necessitated explicit operational definitions because we wanted to focus our specialized resources on patients with imminent housing crises. And specifically, it's the bottom definition for stably housed patients who desire a change that needed the most refinement, because these are patients that we refer to community partners for support, and we do not serve them within our program because their housing needs are less pressing. So we focus on homelessness, patients at risk of eviction, and patients with unsafe or unhealthy housing. Next slide. Given that, and given that screening increases identification, most evidence comes from programs that focus on unhoused patients, and less is known about programs like this. We aim to do an evaluation of more than 1,000 patients who participated in the housing program and 5,000 matched comparison patients. This was a retrospective mixed methods evaluation that aimed to answer 3 questions. The first was the housing program participation associated with differences in healthcare use or chronic disease control? The second was, who are the patients served and the services provided? And then the last was a series of interviews where we sought to understand from the patient's perspective what their experiences in the program were and what were their perceived effects on their health and well-being. Next slide. Our first finding is that the housing program participation was associated with reductions in healthcare use. The top light yellow box shows there were no associations with emergency use, inpatient use, but there were associations, a reduction in 3.6, housing program participants had 3.6 fewer visits than matched non-participants and 2.5 fewer primary care visits. If we get the next slide, you can see that this reduction was driven, was driven by an 81% reduction in social work visits and a 60% reduction in behavioral health, psychiatry, and urgent care visits. Next slide. The second finding is that the patients served by this program were higher risk patients at baseline. Demographically, they were 70% female, 30% younger than 20, and 60% Spanish speaking. And on the right, you can see that in comparison to the Brigham Health primary care population in general, they were predominantly Medicaid insured and had a greater proportion of Black and Hispanic patients. At baseline, they had more healthcare utilization and were more likely to have chronic conditions, hypertension, diabetes, and depression. But interestingly, the chronic disease control was similar between the 2 groups. Next slide. On the left, you can see that the majority of the patients served by the housing program were in the 3 housing case types we prioritized: those at risk of eviction, homeless, or experiencing unsafe or unhealthy housing. 30% were still in that stably housed category, and that is because the triage was developed during this evaluation period. Next slide. The project findings that are most compelling to me are the patient voices. And what you see here is 4 themes. The first of which is patients participate in this program because of compounding stressors. There were multiple things that led to their participation here. The second one is that there are health improvements associated with their new housing. So the patients reported, and if you look at the bottom, living here, my health has improved. Before I came here, I was already at the peak of being diabetic, but today I've gone to the clinic and they've done tests in which the result is that the threat of becoming diabetic has disappeared. I've lost about 40 pounds and I feel better. I feel more agile having lost those pounds. Next slide. The third theme is that patients reported improved mental health, not only associated with their new housing, but associated with their interactions with their housing advocate. This was the most consistent theme of the interviews, that people deeply appreciated the support that they received. So the first quote, I think, is very
I need you to move to the last thing, please.
All right. So let me go to the next slide. Next one. You know, it's rare to find a healthcare housing intervention that supports patients upstream like this. The null impacts on chronic disease control with 1 year of follow-up are not surprising. Some of the studies in the literature find those impacts 4 to 7 years later or 10 to 15 years later. But these outcomes were included because hospital administrators seeking sustainable program funding report that absent significant operational impact, arguing for institutional investment is difficult in a setting of constrained resources. So one of our key recommendations is introducing broader measures of success, including social return on investment, reduction in school absenteeism and work absenteeism, and others. These programs can't be judged only on their healthcare utilization impact. And the patient voice really makes visible hidden benefits that are included in their health, but also the support and compassion that they receive from the care team as they experience housing stressors and indignities. Our last slide holds our recommendations that we recommend refining these interventions to address imminent housing crises and forging cross-sector partnerships necessary for innovating broader measures of success, rendering screening actionable rather than only asking patients about needs and leaving the care team to hold those identified needs, know what the solutions are, and feel powerless to enact them, which is the cause of moral injury and burnout in healthcare. And that we should also do more to advocate and create more affordable housing. Any program, including ours, that's predicated on outcompeting others for scarce existing resources may have a powerful impact, but will have limited reach. Thank you very much.
Thank you. Hi, I'm Katie Huber. I'm a senior policy analyst at the Duke-Margolis Institute for Health Policy at Duke University. And I'm really pleased to present today about our new research article on addressing housing-related social needs through Medicaid, based on lessons from our study of North Carolina's Healthy Opportunities pilots. Before I begin, I'd like to thank Health Affairs for organizing this theme issue and briefing event, and also acknowledge my large team of co-authors who are listed on the slide here. Next slide, please. North Carolina offers one of the nation's most expansive Medicaid programs to address health-related social needs through its Healthy Opportunities Pilots program, which was created using a Section 1115 waiver authorities. At a high level, the pilots aims to address 4 domains of health-related social needs, including housing. And the delivery model involves 3 regional networks of community-based organizations, or CBOs, that provide pilot services. And then they receive reimbursement from the state's Medicaid managed care plans who manage the program funding. The pilot's housing domain includes 9 services, which we classify into 3 categories. Housing navigation case management supports enrollees in finding and maintaining stable long-term housing. Housing quality and safety modifications include services to eliminate home-based health and safety risks. And housing and utility cost mitigation, which includes coverage of certain expenses related to securing housing, such as first month's rent. Next slide, please. So our objective for this study was to identify lessons learned, innovations, and actionable insights from the design and implementation of the pilot's housing services to help inform the efforts of other states and federal policymakers who are working to address housing insecurity through Medicaid at scale. To do this, we used a mixed methods approach. And for the qualitative portion, we spoke with people involved in the design and implementation of the pilots through key informant interviews and expert stakeholder meetings. We also held 2 focus groups with community members who had experiences with North Carolina Medicaid and pilot services. And we also analyzed quantitative data on local housing problems and pilots' housing service delivery to understand how housing needs vary across the state's geography and how pilots' housing service delivery accounts for that variation. Next slide, please. So from our research, we identified 4 cross-cutting themes that highlight promising practices for housing service design and implementation in Medicaid, and I'll provide an overview of those in the next slides. In our first theme, we describe how the housing landscape varies within and across the pilot's regions, with features that make them distinct from one another and from other areas of the country, with important implications for addressing housing needs. We write about these in more detail in our article, but for some examples, the coastal part of the state is vulnerable to hurricanes, and interviewees in the eastern and southeastern regions said that this creates housing challenges in their regions. Interviewees also told us that the southeastern region includes coastal areas where most construction is for luxury properties, which contributes to insufficient affordable housing in the region. And the Western Pilots region has the highest proportion of older homes with inadequate plumbing. So together, we found that these landscape features really contribute to variation in severe housing problems, which are shown in the figure on the right, which influence the distribution of pilots' housing services that have been provided to date across regions, as shown in Exhibit 2. The Department of Housing and Urban Development defines severe housing problems as housing units with inadequate kitchens, inadequate plumbing, overcrowding, or housing cost burden. So in each pilot's region, we identified census tracts in the top quartile statewide for each problem, and then categorized them into tracts with quality issues, so units with inadequate kitchens or plumbing, and tracts with availability issues, units with overcrowding or housing cost burden. And we found that the Western region had the highest percentage of tracts with significant quality issues, which are shown in the map in orange. The Southeastern region, in contrast, had the highest percentage of tracts with significant availability issues, which are in dark blue. And the Eastern region had the highest proportion of tracts with significant challenges in both quality and availability, which are the red areas of the map. And as you'll see in the figure on the right, we observed that the distribution of pilot services provided in each region was influenced by the distribution of severe housing problems that were shown in the map. And so together, these findings really point toward the importance of developing programs with diverse service offerings to be able to meet a range of housing needs. Next slide, please. Our second theme discusses the complexity of defining and pricing housing services. Several pilots' housing services have flexible definitions to cover a variety of needs. Our interviewees told us that they appreciated this flexibility as it allowed them to creatively meet people's needs, but also noted some key limitations of some service definitions. Pilots' housing services were also difficult to price to accommodate this flexibility in service definitions. The housing domain contains the program's most expensive services. For example, accessibility and safety modifications authorize up to $10,000 per enrollee. But interviewees told us that caps on some services were still too low to meet their clients' needs and to cover the true costs of service delivery. For other programs, we present several considerations related to defining and pricing housing services, including pairing flexible service definitions with appropriate quality guardrails and continually reassessing service prices to ensure they reflect the true cost of services in the context of changes like inflation. Our third theme describes how successful implementation of housing services depends on engaging diverse stakeholders. And while engaging stakeholders outside of the health sector is really important for all social needs domains, the housing domain involves working with several unique stakeholders with important nuances. For example, many of the pilots' housing services require CBOs to work with landlords, a third party with legal rights pertaining to enrollee services. And while many CBOs working in other domains deliver services themselves, many CBOs providing housing services had to contract with independent construction contractors to provide these services. So we learned that many CBOs in the housing space leveraged housing-related partnerships and infrastructure outside of the pilots to assist with this added complexity and to provide additional assistance to clients. Moving forward and for other programs, closer partnerships with housing and social service infrastructure beyond the health sector could be helpful for addressing housing needs beyond Medicaid. And lastly, our fourth theme highlights the need for creative financial models to sustain CBO capacity. Because housing is the most expensive pilot service domain, and because of the program's current reimbursement model design, upfront costs for service delivery can become increasingly unmanageable for CBOs as referral volume increases. Pilot entities have just developed a few creative short-term solutions to help address this, which we read about in our article. And in the longer term, and for other programs, there's interest in exploring a transition to alternative payment models to provide more flexibility and a path to sustainability. Next slide, please. So we hope our research motivates continued innovation and progress in addressing health and housing-related social needs through Medicaid. And with that, I'd like to thank you for your time, and I look forward to the discussion.
All right, thank you everyone for being here. So my name is Alec Chapman. I'm a data scientist at the University of Utah and a PhD student in biostatistics. And I'm going to be presenting on some work with this great team of people here that we've been doing in the Department of Veterans Affairs. So next slide, please. So veterans are historically overrepresented in the homeless population. And the VA has really put a lot of effort in the past 20 years or so to address this. And one of the ways that they've done this is they've opened and run a number of very large homelessness programs for veterans who are either homeless or at risk of becoming homeless. And one of the largest of these is a program called SSVF. And this is really the VA's kind of rapid response approach to homelessness, where it's meant to be very quick and a very immediate response to a veteran who is experiencing housing instability. A critical component of SSVF is something called temporary financial assistance, or TFA. And this consists of flexible, time-limited payments for helping these veterans pay for housing or for other housing-related costs. And so previous work has shown that this TFA really leads to a higher likelihood of being stably housed at the time of exiting the program. And that typically takes about 60 to 90 days of program enrollment. But long-term impact of this hasn't been studied. And this is partly because of the difficulties in collecting long-term outcomes of housing status. And so on the next slide, I'll kind of outline the objective of the study. So we wanted to look at that long-term impact. So going beyond kind of the rapid response and the immediate short-term outcomes, does temporary financial assistance extend to improving long-term housing outcomes as well? So in the next slide, I'll go through some of the methods of this. And so, like I said, one of the challenges of studies like this is actually collecting housing outcomes. So we turned to a number of different data sources, and one of the crucial ones was the VA electronic health record. And so from the VA EHR, we looked at a cohort of veterans who were enrolled in SSVF between fiscal years 2016 to 2018. It was about 35,000 patients. And we collected from the EHR baseline covariates like demographics and comorbidities. We also used the EHR to look for housing status. And in the specific, we looked in free text clinical narratives. So these are like physician progress notes or social worker notes that document patients' care and can also talk about their housing status. And we used natural language processing system that we had developed for this purpose. And this NLP system identified mentions of housing status in notes, and we used that to derive a longitudinal variable of a binary unstable versus stable housing. And we looked at this for 3 years after a cohort of veterans had enrolled in SSVF. And the goal here was to compare over those 3 years the difference between patients who receive and don't receive TFA. So on the next slide, this will show the main findings of the primary analysis. So among the entire cohort, we see in the orange on this graph over on the right, this really sharp reduction in housing instability after they enter the program and receive TFA. And so after about like 90 or 120 days or so, there's been a really rapid drop. But after that, there starts to be a little bit of an uptick, as some of those people who had previously found stable housing might start experiencing housing instability again. And when you compare this to the group who was in SSVF but not receiving TFA, you see they also decreased housing instability, but it was a slower and much more steady process. But after about 420 days, so a little over 1 year, these two groups showed pretty similar outcomes. And for the remainder of the 2 years of the study, these two groups were fairly similar. Now we can break this up in the next slide, looking at patients who were either homeless at the time they entered the program versus who were at risk of becoming homeless. So rapid rehousing patients, that's where we saw the largest effect. And so we saw, again, that really sharp decrease in TFA compared to no TFA, followed by, after about 1.5 years, similar outcomes. In homelessness prevention, so these patients, there was less of a dramatic effect, and it was more short-lasting. But we did see in the no TFA group that some of these patients actually increased in housing instability. And so this could suggest that TFA is potentially, acting as a protective measure for these patients, and they actually saw some deterioration in their housing instability after entering. And so in the last slide, in the next slide, I'll kind of summarize some of the findings of this. So similar to previous results, we see that TFA really is effective at improving short-term housing outcomes. And one of the contributions of the study is that we could see the timing of this was really rapid, this very sharp and sudden decrease. But we also see that starts to wear off after a little while. And so the effect attenuates after about 3 months, and after about 1 year or so, there's really not too much of a difference between patients who received TFA and those who received other services in SSVF. And so a response to this could be combining these rapid rehousing services through SSVF with other services like shallow subsidies. This is sort of like an extension to TFA that we're starting to look at that is longer lasting and more flexible, or combining SSVF with permanent supportive housing programs like HUD-BASH, another large VA program. And so with that, thank you for being here, and I look forward to any discussion.
Great, thank you all. We have a lot of really interesting, almost technical questions from the audience that I'm not going to be able to get to. I'm going to try to step back, given the limited time that we have for Q&A. I do want to ask, I'm going to start, Katie, with you. When you describe sort of the complexity of this initiative, at the outset of this event, I said that a lot of health systems are trying to figure out what to do in housing. You're an entire state with one agency trying to figure out what to do, and you're running into those levels of complexity. I just wonder your reflections on what came out of your work for a health system that's trying to do something in this area. Are you daunted by it? Do you think it's overcomable? Curious your thoughts.
Thank you. That's a great question and something we've kind of heard before. I think there's definitely opportunities to do something similar, but at a smaller scale to get started with. And I think there's definitely lessons from this more expansive programs that can be adapted to a health system, for example. So some of our other work studying the program has really highlighted the need for some of the upfront funding to get these kinds of partnerships and infrastructure needed to really stand up and sustain programs like these, and really need more of like the technical infrastructure as well, as several of our colleagues have touched on, kind of the technical infrastructure that's needed to make referrals to different sectors and make sure that those needs are met. And so I think there's definitely complexities, but something that is definitely possible.
Well, that relates then to sort of a broader question I want to reflect on between the pretty powerful findings, MaryCatherine, from your piece. But Alec, you're showing that the effects fade fairly quickly of the temporary assistance. How do we think about the duration of support necessary to have an effect, a lasting effect, and the ability of the health sector, whether it's through an individual system, a Medicaid program, the VA program, the ability of the health sector to sort of take on what we know is a long-standing, complex, multidimensional problem. So it's a fairly broad question, but I'd love your thoughts on sort of how do we think about aligning duration, supporting patients, and program capacity and design. MaryCatherine, you want to start on that?
Yeah, I'd love to. One of the things that our program does is it works in partnership with community-based organizations, state-based and city-based entities. And that's not only for the patients we don't use housing advocate support, internal housing advocate support for, but we have a relationship with the Department of Temporary or Transitional Assistance. We have relationships with community organizing and other housing advocates in the city, and specific programs that provide services for homeless elders, for example. So our goal is, if there's someone else out there who will help this patient, then we articulate the need, we connect the patient, and we provide the stuff that only the healthcare sector can, right? Like physician support for reasonable accommodations, communication with the social worker. And then for patients for whom there isn't a good solution, or they're not able to engage with that solution for a variety of reasons, our housing advocates are really good at building that trusting relationship and doing an company-based model with a patient who needs it. Our goal in terms of working on housing is really to look for housing solutions that are permanently sustainable with the income the patient has. Now that means we're really looking at patients who have some income. Right? There are patients who have no income, and we don't have a bridge to a permanent housing solution for them. But I think, healthcare has specific things we can bring to the table in terms of the clinical expertise, the identification of these needs. And one of the things our partners tell us is we are finding patients who don't show up in the places where other supports are available. And our housing supervisor does a great job of linking patients who can be linked and putting patients on caseloads of our own housing advocates who really can't be linked to another system, or who need this done in partnership with their clinical team, their behavioral health team, or someone else.
That's great. Thoughts from either Alec or Katie on this?
Yeah, I mean, MaryCatherine talked on just a lot of really great points. And one that she brought up is, the importance of kind of working with the community. And I think that's been really crucial to SSVF's success, because SSVF in particular works with kind of local community organizations rather than just working through like VA health clinics directly. And so I think, yeah, it takes, a village to address these big structural issues. And so integrating as many people as possible. I think also, just kind of being able to measure and follow. And that's, kind of a unique challenge that when you're getting a lot of services, it's easy to fall through the cracks. It's easy to not, kind of receive the follow-up that you need. And so improving that and improving the visibility around that, I think is important.
Definitely agree. I think the only thing I would add from the North Carolina perspective is the program has really emphasized this no wrong door approach where folks can kind of get connected to the program either from their health provider or care manager, but also through a CBO referral, through a self-referral. And so really trying to make links to the healthcare system and to that program, even if someone is not currently accessing care. So trying to get that as wide as possible.
Well, I hate to cut this off, but we have a lot of papers. But I really appreciate the range of interventions you all presented, and this notion that, of course, these problems are bigger than healthcare can solve, but there are distinct roles that distinct elements of the health system can play that are unique, that have an effect, that are meaningful, and are definitely worth doing. And we need some humility, but we also need to not be stymied in our efforts by the notion that the problem is so large that we can't solve it. There were a number of questions from the audience about why are we bothering, and I think you all gave a good answer to both the limitations but also the potential. So I appreciate that. Thank you all, and I'm now